A man walks into the emergency room at 11 p.m. His blood pressure is 70/40. His abdomen is rigid. The bedside ultrasound takes 4 seconds. His aorta is the size of a baby's head. It has torn open. He has been bleeding into his abdomen for hours without knowing it. 81% of people with a ruptured aorta are dead before the day is out. Not dead without treatment. Dead. Surgery only changes the math. 37% still die on the table. The surgeon paged for this is a vascular surgeon. Level 1, the medical student. Medical student, third-year sub-internship, vascular surgery service. Salary, 0. Debt, $205,000 and counting. The morning starts at 4:45 a.m. You are the first person in the unit. The seniors arrive at 5:15, the chief at 5:30, the attending at 6. By 6:15, you are scrubbed. The first case is an open repair of an abdominal aortic aneurysm. A nurse hands you a lead apron. You lift it onto your shoulders and feel the weight come down, 20 pounds, distributed across the trapezius. The thyroid shield clicks shut at the throat. You will wear this for the next 4 hours. The attending opens the abdomen. You see something you didn't know you were going to see. A living aorta, pulsing under his fingers, an inch from your hand. The retractor in your hand stays exactly where he told you to hold it. You don't move. The pulsing keeps going. You are watching the central artery of a living human body. Between cases, you write the notes. You present each post-op patient to the attending in 3 sentences: labs, wounds, plan. You eat a granola bar standing up at 1 p.m. The next case is at 1:30. Most students who rotate vascular do not pick vascular. The ones who do decide here. The integrated path is one of the hardest matches in medicine. About half who apply get in. You apply anyway. The application goes in September, 15 interview flights from October to January. You rank your list in February, you submit it, and you wait. 6 weeks, no phone call, no update. The algorithm runs on a Monday in March. Match day. You match into vascular surgery. Level 2, the intern. Intern. PGY1. Your first year out of medical school. Salary, $64,000 to $89,000. 5 a.m. pre-rounds. 30 unread overnight labs in your inbox. You round on 6 patients before the chief gets in. You write the morning notes by hand because the EMR is down again. The pager goes at 6:11 a.m. Bedside consult, post-op patient on the floor, leg is white. You walk down the hall. The patient's right leg is modeled below the knee. The foot is pale. There is no posterior tibial pulse. There is no dorsalis pedis pulse. The toes are cold to the back of your hand. Acute limb ischemia. The vascular textbook calls it the 6 Ps. Pain, pallor, pulselessness, paresthesias, poikilothermia, paralysis. You memorize that list in second year. Right now, you are looking at 5 of the 6. First set of hands, most junior in the building. You page the chief. The chief calls back in 40 seconds. He asks for the ankle brachial index. You don't know it. You walk back to the bedside with a Doppler and a blood pressure cuff. Arm pressure, 134. Ankle pressure, 68. The ratio is 0.5. You call the chief back with the number. The 80-hour cap exists. Nobody logs the violations honestly. The program would lose accreditation. You eat your second meal of the day at 4 p.m. in the call room in scrubs. Your phone has 14 unanswered text messages. You will answer them on Sunday. The leg gets to the operating room. The patient keeps it. The next pager goes at 8:14 a.m. 2 more years, PGY 3. Level 3, the senior resident. Senior resident, mid-residency. Salary, $72,000 to $100,000. 500 cases logged, most of them as the assistant. Tonight, you are the surgeon of record on an open AAA repair, and the attending is across the room watching. The patient is 72. You are clamping the iliac. The vein behind it tears. The field fills with blood in 4 seconds. You find the tear. You sew it. The patient survives the operation. One vascular fellow described that exact moment in an online AMA. We can handle what most surgeons are afraid of: bleeding. You read it during intern year. Tonight, the line lands in your hands. A few weeks later, a different case. Not a death, a complication. Fem-pop bypass on a 66-year-old smoker with rest pain. The graft thromboses on post-op day 3. You take the patient back to the operating room. You declot the graft. The patient keeps the leg. 6 a.m. on a Friday, you stand at the podium of the M&M conference with the case sheet in your hand. M&M, morbidity and mortality, is the surgical confession booth. 40 residents, 20 attendings, the chief of surgery in the front row. You present the case in 5 minutes, the pre-op presentation, the intra-op decisions, the post-op course, the miss. You say the words, "I missed it," into a microphone in front of a room of people who will be your colleagues for the rest of your career. You return to your seat. Another resident takes the podium. Everyone in the room forgets the case by Tuesday. You remember it for years. By PGY5, you run the room. Level 4, the chief resident. Chief resident. PGY5 salary, $73,000 to $110,000. 2 a.m. on a Tuesday, you are the senior person in the operating room overnight. The junior on call pages, you about a 61-year-old in the emergency room. Cold leg, no femoral pulse, mottling above the knee. Atrial fibrillation on warfarin, last dose unclear. The junior wants to know if it is acute limb ischemia, category 2A or category 2B, meaning salvageable or about to be lost. You walk down to the emergency room and feel for the pulse yourself. The patient says his foot stopped feeling like his foot around 8 p.m. It is now 2:14 a.m., 6 hours and counting. You make the call. The operating room gets paged to set up. The attending gets called at home. You walk down the hall to the family waiting area where the wife is sitting in a green plastic chair. The line you say to her is the line every vascular surgeon eventually says. "We are going to try to save the leg. The leg has been without blood for 6 hours. At 6 hours, the math starts working against us." She nods. She has been the wife of a man with atrial fibrillation for 19 years. She has rehearsed this conversation in her head before. She just didn't know it would be tonight. 93% of practicing vascular surgeons take first call for their hospital. 64% are on 1 in 4 nights and weekends. The chief year is the dress rehearsal for that schedule. The job starts to feel doable. You also start to feel old in a way 28 should not feel old. The leg makes it to the operating room at 3:02 a.m. Your boards arrive in the mail. You sign your first attending contract. Level 5, the junior attending. Junior attending, first year out of fellowship. Salary, $380,000 to $440,000. The page comes at 3:07 a.m. Your wife stirs and goes back to sleep. She has been waking up to this sound for 10 years. She does not ask anymore. 68-year-old male, hypotensive, abdominal pain radiating to the back. Bedside ultrasound shows free fluid in the abdomen and an aneurysm, quoting the emergency room doctor verbatim, the size of a baby's head. Home is 14 miles from the hospital. You start the car. There is a granola bar in the glove compartment. You eat it on the highway. On the speakerphone, you call the operating room. You tell them you need a vascular tray, a level 1 infuser, 16 units of blood cross-matched, and a Foley. You call the senior partner because nobody does the first solo rupture without backup. He is on his way. He is 40 minutes from the hospital. The patient is 40 minutes from being dead. The math, as it stands at 3:08 a.m., operative mortality for a ruptured aortic aneurysm runs between 25 and 50%. The patient on your table tonight does not meet criteria for the less invasive option. You will open him. You scrub. You gown. The lead apron goes on at 3:23 a.m. The weight comes down on your shoulders the way it has every day for 10 years. Tonight, the weight feels normal. The weight has become invisible. You open the abdomen, you cross-clamp the supraceliac aorta in 12 seconds. The rupture comes into view. You repair it. You release the clamp. Pressure stays at 0. You try for 90 more minutes. Anesthesia gives more product. You squeeze the heart in your hand. Pressure stays at 0. The patient dies on the table at 5:11 a.m. You take off the gown, you wash your hands. The walk to the family room is 40 feet. You tell the family, you do not cry. Not in the family room, not in the surgeon's lounge, not in the parking lot. You sit in the car for 2 minutes. You start the engine. You drive home. René Lariche, the vascular surgeon whose name is on a syndrome of the iliacs, wrote it like this. Every surgeon carries within himself a small cemetery, where from time to time he goes to pray. Yours starts tonight. 6 a.m. rounds are at 6. You round on 6 patients. You write your op note. You bill the case. You go to clinic. The team does not know about last night. You do not tell them. The pager fires again at 5:28 a.m. Different patient, different leg. Level 6, the mid-career attending. Mid-career attending. 8 years out of fellowship. Salary $620,000 to $721,000. The clinic patient is 64. Diabetes for 23 years. End-stage renal disease for the last 6. She has been your patient for the last 4. You know her husband by name. You know her daughter is in nursing school. A Wagner 3 ulcer on the right great toe that has not healed in 8 months, despite 3 revascularizations, 2 debridements, and 4 rounds of antibiotics. The wound has not changed in 2 months. You sit on the bed. You tell her the leg cannot be saved. The technical name is critical limb-threatening ischemia, WIFI stage 4. You start with the plain version. The leg has to come off above the knee. The surgery is on Friday. She asks if the other leg is next. You give her the truth. The contralateral leg is at risk. You will see her every 3 months. You will check the pulses. You will send her for vascular studies. You cannot promise her she will keep it. She nods. She has a notebook. She writes the date of the surgery. She writes the name of the procedure. She does not write the words you said about the other leg. Tuesdays and Thursdays, you operate. Wednesdays, you do dialysis access. Saturday nights, you take call. The dramatic cases, the ruptures, the cold legs at 3 a.m. are about 10% of your week. The other 90% is this clinic. Patients you have known for 6 years. Patients you have known for 10. Patients you have watched go from working to homebound to dead. Black, Hispanic, and American Indian patients lose limbs at higher rates than white patients. The disparity persists after controlling for diabetes, hypertension, smoking, and income. It is a Tuesday afternoon at 1:30 p.m. The patient in front of you is the data point. You revascularize the right leg in 2020. The right leg comes off in 2022. The left leg comes off in 2026. 18 months after the second amputation, you read her name in the hospital newsletter. Same patient. 3 operations, 1 obituary. The cemetery you have been carrying since the first solo rupture grows on a single name. 10 more years on the schedule. The lead apron stays on your shoulders. Level 7. The senior partner. Senior partner, section chief, salary, between $774,000 and $1.3 million. You have worn lead for 15 years. 82% of vascular surgeons report lower back pain in the past year. You are one of them. The orthopedist appointment is on your calendar. It has been on your calendar for 14 months. The lead apron is 20 pounds today. It used to be 30. The new design is lighter. The old back is the same. The apron goes on at 6:53 a.m. The trapezius does what it has done 8,000 times. The thyroid shield clicks shut at the throat. You stand straight. The weight is permanent in the curve of your spine now. The apron comes off at the end of the day, but the spine has stopped going back to where it was at 25. The chief resident this year is the one you wanted. She finished the open AAA repair last Tuesday with no help from you. You stood across the room and watched. After the case, you said 5 words to her in the scrub room. You can. You will. Keep going. She remembers them. You remember the attending who said them to you in 2004. Some of your peers leave the hospital. They open office-based labs, OBLs, where they do procedures on their own terms. Fewer hours, less call, more money. The field is divided. Some surgeons see a legitimate outpatient model that lets them keep doing the work without hospital overhead. Others see a reimbursement-driven drift toward procedures that may not be necessary. The partner 2 years ahead of you in fellowship took the OBL path. You stayed at the hospital. He goes home for dinner most nights. You eat dinner at the hospital cafeteria most nights. He has the boat. You have the operating room. Neither of you would trade. The chief resident this year does not yet know what the lead apron weighs in 15 years. She will. You will not tell her. The math has to come out of her own body the same way it came out of yours. The cemetery you have been carrying since the first solo rupture is full. End of the day. The operating room is dark. The case sheet is signed. You unclip the thyroid shield. You lift the lead apron off your shoulders. 20 pounds, gone in 2 seconds. The spine does not go back. It has not gone back since you were 25. You hang the apron on the rack. Your name is taped to the hook. The curve in the shoulders is yours alone. The pager rests on the desk. The next call comes by midnight. You walk to the parking lot. The surgeon's lounge is dark. You pass an empty family room. You sit in the car. You do not start the engine. René Lariche wrote it like this: every surgeon carries within himself a small cemetery where from time to time he goes to pray. The cemetery is full of names.